Okay, so in our last video we talked about hypoparathyroidism, and now we're going to move on to hyperparathyroidism, but I just wanted to give you an overview real quick. Remember that because the calcium is low in the serum, there's not enough in the muscles themselves, so they can spasm because they're not getting the charge, the electrical charge that they actually need to perform normally. So the serum amount of calcium is not regulated, and the biggest issue is nerve issues. So with hyperparathyroidism, remember the calcium is high. Hyper means high. The calcium leaves the bones and it's in the serum. So you have some really weird things going on with the body because there is high calcium in the serum and low calcium in the bone. The bones can break, and osteoporosis, all of those things, demineralization of the bones can happen. High levels of phosphate are excreted by the kidneys because remember, in hyperparathyroidism we're holding on to the calcium. Again, you're going to see opposite of hypothyroidism, where you see twitching and muscle stimulation. You're going to see muscle weakness, you're going to see heart failure, fatigue, nausea and vomiting, skeletal tenderness because those bones are so brittle, pain when they bear weight, pathological fractures. And a pathological fracture, if you don't know what that is, that's the little old lady who breaks her hip and then she falls. The muscles deteriorate, or the bones deteriorate, and they just break. They break with normal activities of daily living, not so much trauma. Very dangerous kind of thing. When someone has a parathyroid issue and they're either hyperparathyroidism, even regular thyroid issues, they do a lot of bone density studies because they have to figure out what's going on with the calcium, where it is, and if the bone density is decreased, then they have to give medications that bring that up. So in order to regulate the calcium amount in the serum, they're going to start with simple things like fluids and diuretics to try and flush it out of the kidneys. They're also going to give phosphate therapy because remember, if the phosphate's high, the calcium goes low. So if they can add extra phosphate, basically phosphate and calcium can't get along together, and so then the calcium will leave. And then calcitonin, which basically uses up calcium and then also redirects it to where it needs to be, which is in the bones. And you'll see drugs like Fosamax being used. These are used for osteoporosis, and basically what they do is they help through the kidneys. Calcitonin affects how the kidneys use calcium, what they do with it, and more calcium is then excreted, and more is absorbed by the bones. And the Fosamax helps keep the calcium in the bones. Again, this is pretty intense A&P and chemistry, but what I want you to know about is if they have high serum calcium, they're at risk for pathological fractures, and you got to do what you can to keep this patient safe so that they don't have fractures that are unintentional, and you can keep them healthy. And one way to do that is to increase their muscle strength. So muscle strengthening exercises really help because the stronger the muscles are, then the less of a hit the bones will take. If they're going to remove the parathyroid, which sometimes they have to, the post-op care and risks are exactly the same, including thyroid storm, because you're messing with the thyroid. Nursing interventions. Early treatment is best, especially with women who are aging. They're always watching their bone density, calcium levels, to make sure that we keep as much calcium in our bones as we can. We'll use a lot of fluids, again, weight-bearing exercises, and that's to increase the muscle strength. We want things to be safe. This is where you might come into one of those throw rug questions. And again, smoking cessation. You know, when people smoke, it does everything bad to every organ, and smoking does not help in this kind of situation. And then, of course, we're going to talk to our patients about the use of calcitonin, the use of drugs like Fosamax. I highly suggest you make a list of the meds that are on these PowerPoints and just get a brief understanding. You can use that same chart we did for the neuromeds. And again, do with it what you want. It's a learning tool. And take a good look at what these meds do and what the nursing interventions are for them. So the next topic we're going to talk about in our endocrine journey is the adrenal glands, and we're going to talk about 3 different issues that can arise with dysfunctions of the adrenal gland. The first one is pheochromocytoma, very, very rare. The second one is Addison's disease, where the adrenal glands are just insufficient. And the third one is Cushing's syndrome. So if we're looking at the adrenal glands, they sit atop the kidneys. You can see here is a kidney, and here's the adrenal gland. And they call them the M&Ms because the adrenal gland is very hard on the outside and soft and squishy on the inside, just like an M&M is. The functions of the adrenal glands are threefold. So remember the 3 S's: salt, sugar, and sex. And basically, the aldosterone that is secreted by the adrenal glands promotes the retention of salt. Cortisol, another hormone that is excreted by the adrenal glands, affects the metabolism of chlorides and sugars. And then androgens are the sex hormones, and they're also excreted by the adrenal glands. So those 3 S's help reduce inflammation, cope with stress, and again, regulate sexual function. So if you look at the adrenal cortex, that's the top. It secretes glucocorticoids or cortisol. They affect metabolism, they suppress inflammation, and they help the body with stress. And then they also excrete aldosterone, which is a mineral corticoid, and this controls our sugar and electrolyte water balance. The medulla section of the adrenal glands secretes neurohormones, epinephrine and norepinephrine. These are the fight or flight hormones. They have to do with constriction of the blood vessels, all of those things that in a situation of anxiety that basically protect our lives. So if you're looking at the disease processes we're going to talk about pheochromocytoma, and this is a tumor of the adrenal medulla. It's very rare, and what happens is it makes the adrenal glands hypersecrete catecholamines, and catecholamines are epinephrine and norepinephrine. It's very rare, and if you imagine going into a fight or flight situation, you know, your heart starts to race, your blood pressure goes up, you have high anxiety, tachycardia, you're probably sweating, your bowel stops working. Imagine that happening and then not stopping. You know, you have a fight or flight situation, something scares you, you know, you're running, whatever the situation might be, but it comes to a stop, and usually pretty quickly. But in pheochromocytoma, it doesn't stop. So imagine that fight or flight feeling all the time and how exhausting that would be. This is diagnosed by a 24-hour urine, and they're looking for metanephrine, which is basically an excretion of a byproduct of catecholamines. And they look for it in the urine, they look for it in the blood, and then they also do a CT and MRI of the adrenal glands. It's managed with surgical removal of the adrenal glands. First they try to stabilize the patient, then they use alpha blocking agents they use beta blockers and phenobenzamine. And again, look up those drugs to see what they specifically do, but don't focus on it a lot. Just get an overview and what the nursing management are for those medications. Interventions, you're going to be monitoring their vital signs. Remember now they're going to take out that adrenal gland. So they're going to remove the ability for fight or flight. When they are in the midst of it and they haven't done surgery yet, you're really going to want them to avoid caffeine because the less stimulation, the better. And then we're going to monitor them very, very closely after surgery. We want to keep them injury-free and keep their vital signs very, very stable. The next disorder we're going to look at real quickly is Addison's disease, and this is where the adrenal cortex is destroyed. It's very uncommon, usually caused by cancer, tuberculosis, some sort of pituitary malfunction, or if someone's taking like huge doses of steroids and then they stop them suddenly, then the adrenal cortex kind of freaks out, doesn't know what to do. They think Addison's disease is autoimmune, but it's one of those things that they really don't know what brings it on. But the problem with it is before a patient will have any signs and symptoms, they've already lost about 90% of their adrenal cortex function. With Addison's disease, you're going to see hypotension. Because of the low blood pressure, the body loses, it doesn't have enough aldosterone, and then there's sodium and water loss because of aldosterone's process of what it does with sodium and water, and then tachycardia ensues because whenever you're not your blood pressure isn't normal or your respirations aren't normal, then your heart rate has to increase to fix it. The patient will have a higher excretion of sodium and water. So in this situation, unlike our first diseases we talked about, SAIDH and diabetes insipidus, in this situation water does follow salt, and the salt in the urine is high and the water goes right with it. The patient's very dehydrated, very weak, tachycardic. Their blood sugar goes very low. Really, really dangerously low sometimes. Confusion, weight loss. They have a really bizarre pigmentation problem. They lean towards psychoses if their cortisol levels go very low, and they'll have some nausea and vomiting, which is pretty much the case in any disease. So what they do to discover it is serum cortisol levels, urine cortisol levels. The cortisol levels are low, glucose is low, BUN and hematocrit might be high, but that's only from dehydration. So once they get the fluids on board, that's usually remedied and hopefully no permanent kidney issue. And they'll use ACTH synthetically to and look for that when they're trying to treat it. They have lifelong hormone replacement therapy. Florinef is a drug you'll see. You have to really watch their vital signs, their potassium level. They also give hydrocortisone. And this patient might not, because they've lost their fight or flight, they might not be able to react to stress like the rest of us do. It might be a little bit too chilled. So if there is an adrenal crisis caused by Addison's disease, it's huge amounts of sodium and water are leave the body. Severe dehydration takes over, lots of hypotension, again, tachycardia in the 180s, 200s. The potassium, because of the electrolyte imbalance, the potassium goes really high. When potassium goes really high, cardiac death can ensue really, really quickly. So fluids have to be on board. They have to use drugs to get the calcium out, like Kayexalate, that kind of thing. If an Addison's crisis or adrenal crisis does not remedied immediately, the patient will die usually from